Hello, and welcome to the Health Data Ethics Podcast. I'm your host, Jenny Owens, and I'm really glad to be back after a longer than intended break. I had some travel, I had a traveling spouse, I got sat on a jury for a week and a half. It's been a wild few weeks, but I'm really glad to be back in the saddle and bringing you a paper and a discussion that I've been looking forward to having with you for a while now. I wanted to talk in this episode about a recent paper on AI scribes in healthcare. It's this JAMA Network Open study evaluating really what turns out to be just a bridge in 6 different health systems. This paper breaks down the effect on the physicians at these health systems. What was their burnout like? What was their task load like? I want to put this in context. I want to contrast it with Atrium Health's experience that they documented in 2024 using the Microsoft Nuance's Dragon Ambient experience. I want to compare and contrast and talk about why one of these papers concluded that scribes do have benefit and one of these papers concluded that scribes do not have benefit. And then I want to talk about Epic's announcements at their users group meeting about having a fully integrated Epic native AI scribe based on that Microsoft Nuance technology. I also then wanted to put all of this in context with the MIT study that came out showing that 95% of AI pilots don't deliver return on investment, and talk a little bit about why that is. So this is a stacked episode. We've got lots of content to get to. I'm really glad to be back with you. Let's get started. So the first is this paper that was published in JAMA Network Open earlier this month in October, evaluating the use of an ambient scribe in clinical care. And this paper is somewhat overrepresented in primary care. About 20% of their participants are in primary care or internal medicine pediatrics, but they do have really good representation from other specialties as well, including psychiatry. So that was interesting that they were not just focused on primary care, but they did do a nice broad ambulatory specialty participant group. The study was coordinated by the Yale School of Medicine and enrolled clinicians across 6 other health systems in California, in Texas, in Cincinnati, in Chicago, and in New Jersey. They lasted 30 days, and they used, the publication is primarily based on the pre and post survey to evaluate the clinician experience. So I want to be very clear about what the study is and isn't saying. This isn't a study saying that we used this tool and we were able to add additional patients to our schedule. This study isn't saying we used this tool and we were able to uplift our billing by this much. The study is saying we used this tool and our clinicians felt a particular way. And this is so important and nuanced. This a lot harder a few months ago, but it's still one of the main drumbeats that rolls through all of our AI governance work. Does the tool do what it says? Does it have the benefit you think it's going to have? And do your people feel that benefit? And that's this third question. Do we feel the benefit is what this paper is really aimed at. So I'm delighted to see this. This paper is from 7 organizations that used Abridge. And there's actually Abridge employees in the author list. They're not trying to hide this. This is an Abridge study. And it does read pretty effectively as an Abridge marketing document. So good job, Abridge. The participant group was, like I said, heavily slanted towards primary care, but we did see additional specialties represented. And the evaluation relies on survey assessments. And the survey tool that they put together is very similar to one I've used myself. It's a chunk of the Mini-Z burnout survey, which is a validated tool for measuring burnout, where a 1 on the scale is I'm skipping to work every day singing. I have absolutely no problems in the world. And a 5 is I'm actively handing in my resignation right after I finish this survey. With a 3 kind of being like I am experiencing symptoms of burnout. They are sometimes bothering me. I'm being a little bit flippant about it, but the tool is very straightforward. They also used my favorite tool, the NASA Task Load Index, which measures perceived workload. And as others have in this space, they trimmed it down. So we're not looking at physical demand. We're not really looking at frustration, but we are looking at mental demand. How hard do you feel like you're working? Some crunch around time demand and what level of effort are you exerting? What level of frustration are you feeling as you're trying to do your job of clinical documentation to the best of your ability? So the key results from this paper are really good. Clinicians reported improvements in their perceived control over their workload, and they cited that they had a reduced cognitive load, which is great. Burnout indicators were favorable post-intervention, so using the tool actually did result in a lower self-reported burnout. The one thing that I want to call out, actually a couple things that I want to call out. So this was a short study. They only used Abridge for 30 days. That's a big improvement in 30 days. I wonder if it would tail off as people got comfortable with the tool, as they started to see the the warts and all, or to start to think about possible improvements in the tool, if you rolled this out and if you measured at 30 days and then maybe at 90 days or at 6 months or a year, would that reduction in burnout persist over that time? That's an interesting question. The other real thing that I would really love to have seen in this paper is to marry the subjective assessment of clinicians, their own self-assessed burnout, data out of a dashboard like Signal. Signal, if you're not an Epic shop, is Epic's user efficiency dashboard. It can be used in a lot of different ways, but primarily how a lot of health systems will use it is to tell you how much time are your clinicians spending interacting with Epic in ways that are supportive of clinical care. How much time are they spending in their in-basket? How long does it take them to respond to an in-basket message? How much time are they spending doing documentation? How long does it take them to close an encounter after the encounter appointment time has passed? These kind of things. So I would love to see if we can match how clinicians feel about the tool with what Epic says about how much time they are spending at Epic, with the understanding, right, that you could still be spending the same number of minutes in Epic and feel like it's less time because it's not as hard as it was because the note has already been drafted for you. That's really interesting and helpful to kind of give you a bigger, more nuanced picture of what this technology is able to do. So I want to contrast this. I covered this at the time, but in 2024, Atrium Health in North Carolina conducted a study using what at the time was Microsoft's Dragon Ambient Experience product. They call it DAX for short. DAX was not integrated into their EHR. So in North Carolina, we had a group that was using essentially a standalone non-integrated Scribe tool. And no surprise here, the clinicians reported that the Scribe tool was really only of minimal benefit. They only saw a 7% reduction in time saved. And they saw this reduction by cutting their users in a way that was really interesting. 3/4 of the users were active DAX users, but what it took to be an active user was to put more than 25% of your notes from the tool into Epic. That's not a high bar to clear. And if you're going to see big work reduction and time and burnout reduction, I think you're going to need to see more than 25%. We would want to see probably a transfer rate of more like 80 to 90 to 95% if we're truly going to be receiving the maximum benefit from the tool. But the lack of native integration was definitely a primary barrier to the adoption and the impact in this use case for this other tool in North Carolina back in last year. And the real conclusion that we want to draw from this is that if you don't have integration, you're just adding another tool into the system and making people click and shift and move things around manually. That's friction. That's not benefit. That's friction. That's not going to help people save time. People are going to skip it, especially if what the tool is producing is not an absolute barn burner of a note. Now I want to talk about what happened this year at Epic's users group meeting. UGM is Epic's big, all of our customers come and share how you're using our tool. It's their big conference. At UGM this year, Epic announced that they are releasing their own integrated AI scribe. This is built on the Microsoft Nuance technology, the same technology that's the backbone of DAX that was evaluated in 2024. But the Scribe is natively integrated into Epic. And I think this, for me, is the key differentiating factor because these tools really live or die based on, the quality of the tool output, right? It doesn't matter how well integrated it is or how nice your workflow is if what it puts out is garbage. But also, two, the integration itself, how well it works in your existing workflows. And to have an Epic native tool actually overcomes quite a few hurdles that we saw with the DAX technology earlier. I think this is going to be really fascinating to see how it compares and contrasts to other third-party Scribe tools on the market, like a Bridge from our first paper, or like others in this space. The other thing that will make this very easy is that then Epic already has very easy measurement of time savings and note quality through their existing metrics. So we have third-party Scribe tools showing really good reductions in self-reported burnout when they're well integrated with Epic. We have a counterexample showing that a tool that's not well integrated is not of much benefit. And then we have Epic itself, the giant of the EHRs, announcing that it is releasing its own native AI scribe tool. This field is really mature in the healthcare AI space. It's really mature. And so I wanted to go back and I wanted to place this in context with one other study that came out earlier this summer. I think it was in August. There was a study that came out from MIT and it caught a lot of press that 95% of enterprise AI pilots fail to deliver on return on investment. And at the time I said I wasn't really surprised because a lot of the AI pilots are generative AI focused. That means that they're using large language models. What do large language models do? They generate text. They generate, and generative AI in general generates text, generates images, video. These are not generally, unless you are a content creation firm, these are not generally your revenue creating areas, right? Where generative AI is useful is, if I think about our sales metaphor, right? It's top of funnel, right? I'm generating content for social media posts. I'm generating outgoing emails. I'm using a tool that is able to help me keep track of my leads and all of these. So I'm not really surprised to see that 95% of the pilots failed to deliver on ROI, because the ROI on the top of funnel tools and tasks is murky and difficult to really quantify as you start to get through that funnel and get into your true revenue generating tasks. So I'm not surprised to see that. What I do like to see is that ambient scribes match those core strengths of generative AI, right? It's text generation, it's listening to a conversation, pulling out the appropriate points, applying a filter to those points that says this is a medical setting, and these are the traditional metrics of a SOAP note, and this is what's important for billing. And so this is a perfect match of opportunity and core strength of the technology. So I'm not surprised to see that the question is now, okay, this is great that it is reducing our clinician burnout. That in and of itself is valuable. But what is the ROI? If I pay $10 million for this tool, what do I expect to get on my balance sheet at the end of the year? And that is difficult to quantify. Reducing the burnout can be directly translated to dollars in some ways. We can remove the pressure, maybe even of adding an additional patient to the schedule. Let's put that to the side for now, because that is really a very sensitive question. But if you start thinking about what does it mean to have physicians not turn over? What does it mean to have physicians not leave your organization? What does it cost us to source and train and onboard a new physician? I mean, that dollars. What does it cost us when somebody is burnt out and drops down to an 80% of an FTE or a 50% of an FTE, or they increase their administrative or their research or their educational time and they reduce their patient burden? Well, that also translates into direct dollars and cents. I think as we see time go on, obviously in the time span of that first paper, that 30 days, we're not really seeing a lot of turnover. We're not onboarding anybody. That's going to be very difficult to track, but we are going to be able to see, are we losing people? Are we not reducing the FTEs? What is the impact on our workforce? And does this translate into a workplace that is better to work? Because that's the other question, right? Like, it's not always about dollars. It's about our moral obligation as well. If our technology is burdensome to our providers, we do have a bit of a moral obligation to use technology to reduce that burden as well. In conclusion, AI scribes are a great use case for healthcare AI because they're a case where the technology is aligned with the opportunity. What the technology does well is what people would like to do less of. We would like to be spending less time manually typing, dictating, or using smart text to be developing our notes. The Abridged study shows a lot of promise. I love to see that people are self-reporting that they're feeling better about their work, but it does also show the limits of a short study. I'd love to see a longer study, and I'd love to see it married with data out of the EHR. We've learned over the course of the past 2 years that integration is an absolutely crucial success factor for these scribe tools. And the ROI for the AI scribes is going to depend on how we define value. Is it just dollars and cents? Or is treating our caregivers better and making their experience better also valuable in a way that's difficult to translate onto a balance sheet?